Hi, everyone. This is Jamesia Hoyle, the coordinator for the Next Generation Global Health Security Network. Thank you for joining us today for our Next Generation webinar series. Today, we're joined by Maja Carrion. She is the Assistant Director for ProMED at the International Society for Infectious Diseases and serves as a Deputy Module Organizer and Distance Learning Tutor at the London School of Hygiene and Tropical Medicine. She is currently a Doctor of Public Health student at Boston University, where her dissertation work will focus on Chagas disease epidemiology and screening in the United States, with an emphasis on Massachusetts. Maja holds an MPH from Boston University in International Health and a BA from Elon University in Political Science and International Studies. For over 10 years, Maja has led and managed public health projects and research in Asia, Africa, South America, Europe, and the US. Her primary research interests are innovative infectious disease surveillance, screening and treatment programs, disease and vector control, and neglected tropical diseases. Thank you, Maja, for joining us today, and I'll turn it over to you.
Great, thank you so much for having me. So I'm happy to speak to you all today about digital disease surveillance and of emerging infectious diseases and outbreaks, and looking at it through a One Health approach. So just a few of the things we'll talk about today. Just an overview of disease surveillance, looking at traditional methods, what innovative disease surveillance actually is. I'll present a few of the pioneers and some examples of the tools, and then we'll talk a little bit about how really traditional and innovative disease surveillance are complementary systems. Then I'll talk to you more specifically about what we do at ProMED, as well as our EPICORE program, and then I look forward to your questions. So why does disease surveillance even exist? So if you take a look at this map, you can see that over many decades now, we've had numerous outbreaks of diseases all over the world. Many probably that have gone unreported, but without disease surveillance, we wouldn't even have the information that we do have. So starting with traditional disease surveillance. Traditional disease surveillance really operates in a systematic way, and what it's based on is collecting information, doing evaluations, and then analyzing that health information. So as you can see on the right-hand side, you will have a few cases that emerge within the public. These are seen by clinicians or other healthcare professionals who then report on this information to their local health department, and eventually that information makes its way up to the Ministry of Health and maybe other organizations such as the World Health Organization, or depending on who it's of interest to, maybe the Department of Agriculture or different governmental or non-governmental organizations. So that's really the way that traditional disease surveillance has operated. And so what are these sources? So as I just mentioned, different ministries, they might be National Institutes of Public Health, organizations like the World Health Organization, FAO or OIE, collaborating centers, laboratories can report this information as well. And so whether those are public or private or military, academic institutions that may be carrying out specific disease surveillance research in areas, and then non-governmental organizations. So organizations like Doctors Without Borders, who might be going into countries and observing outbreaks. So traditional disease surveillance has served us for a long time now, but there are still gaps. And so I wanted to illustrate this with an example. So let's say we have 5 cases of a disease, and we can take any disease here that we would like, but we have 5 people who have symptoms who have the same disease. And what happens with these 5 people? So the first case decides not to seek any treatment, and unfortunately they pass away from the disease. Now, the second case decides to go to seek care at their local health center. The third case decides to go ask the pharmacist for advice. The fourth case goes on to a traditional healer or some alternative healthcare facility for care. And the last person decides to go to the emergency room and they're admitted to the hospital. Now, where the second case has gone is actually a reporting unit. So this healthcare facility has decided that they will be reporting their, for example, a sentinel site. So they see a lot of, we can say measles, for example. They see a lot of this and they decide that they have an agreement with their local health department and they report every time that they have a case. So in that situation, that case is reported. Now, what happens with the three people, the person who passed away, the person who went to the pharmacy, and the person who went to the alternative, is that these cases now are lost. Oh, I'm sorry. So these cases now are lost. So there's no follow-up to the reporting of these cases because nobody has heard about them. And now the final case, the person who went to and was admitted to the hospital. Now this hospital isn't a reporting unit, but we have an astute clinician there. We have somebody who is who's aware that, you know, measles, for example, is a disease that needs to be reported, and it's important that the local health department hears about this. And so they decide to report it on their own. So in this case, we can see there's 5 cases of the disease, but really outside of the people who actually have the disease, only 2 of them are going to be reported further. So there's pros and cons of traditional surveillance. So the pros, of course, is like I mentioned, that the data is collected systematically, it's accurate, they're credible sources, and there may be, one additional thing is there may be opportunities to provide incentives to overcome non-reporting. So for example, finding ways to get health centers to participate in this routine reporting, or finding ways for the community to participate in routine reporting. But there are also cons. So the system is slow. So there's a slow detection. We'll talk about why this is important a little bit later. But it takes a while for that information to make it through the system. So starting with the case, moving all the way through the healthcare worker, through the local health department, for example, up through the ministry, up until it actually becomes reported to the general public. If things are novel diseases or it's vague exactly what's going on, those may not be reported because, again, there might not be a system in place, or the people who are seeing these cases just may not be sure that this is something that needs to be reported. And again, going back to those sources, because the data is done systematically, usually there's a limited number of sources, which means that the information that is being reported is also limited. So there's gaps that we need to address. So again, these delays, the lack of capturing unusual diseases, and the limited reach of traditional systems. So again, relying sort of on the same sources means that the reach of the system is really limited. So let's shift gears to innovative disease surveillance. So what's innovative disease surveillance? Well, in today's world, where we have so many sources of information and we're constantly being bombarded with, you know, whether it's email, social media, online platforms, there's just all of this information that is out there. And the advantage of that is that it gives us these new platforms and ways to detect things faster than in traditional disease surveillance. So other ways that that innovative or non-traditional information is known as is informal, non-governmental, unofficial, off the record, unconfirmed, unstructured data, and rumors. So of course, a variety of different words, some with more positive or negative connotations maybe, but all of these could be considered non-traditional sources. And so again, so it's something that's outside of this routine surveillance that's been set up. So it's outside of these relationships that the health centers or hospitals have, for example, with their local health department. And so this can be social media. It can also just be people talking. So people talking within their network, within their families, saying, you know, my aunt is sick, she has these symptoms. That somehow moves through the chain, through a network, and reaches somebody who is a journalist, it reaches somebody who's a clinician, it reaches somebody just tweets about it. And then also our media sources, but that aren't really considered sort of traditional disease surveillance, but those are our newspapers, our radios, our TV stations. So a reporter hears about something, and you know, and they write a story about it, or they have a spot about it on the radio, and spread the word that way. So of course, there's challenges as well to innovative surveillance, and the most obvious ones are the false positives and the false alarms. So clearly, you know, we're relying on people who aren't skilled necessarily in identifying diseases or even on how to report diseases or outbreaks. And so there can be these false alarms. Someone thinks that something is Ebola when it's really not, or, you know, or false positives where people are saying, well, you know, there's 20 people sick in my village when really it's just 5 people and the other 15 have something else. So the important thing with that is just really the need to validate the information that's received. And again, we'll talk a little bit more about that when we talk about ProMED. So likewise, there's the pros and cons. So the pros is it's fast, right? So if somebody tweets something out, that's immediate, and we can see that, and we can investigate or move forward with that. And the same with reporting. So even putting together a report can be much quicker than traditional disease surveillance. And it's not constrained to certain events. So we're not just waiting for someone to show up at a health clinic or at a hospital, but rather this could be occurring anywhere, or anyone who sees it can report on it. So there's multiple sources of information as well. So we have sort of the same ones that are used in our traditional surveillance, so clinicians and labs, but we also have these media reports, social media, and anything kind of that's out there on the internet or within social networks, even offline. And what it does is it really leverages this information that's publicly available. So anything that's posted on the internet is generally publicly available, and so that's increasing transparency. So it's easier to say, this is my source, and this is where it came from. Whereas with traditional surveillance, sometimes that's not quite as simple to tease out. But there's the cons as well. So like we talked about, the false alarms, the false positives, the information just might not be that accurate, or it might not be significant. It might not actually be important or be what people necessarily think it is. There's obviously a bias that can be present. So in the information that's chosen to be shared by people can be biased one way or the other, depending on sort of what their objective is. The case definitions, again, this goes back to someone being trained to identify outbreaks or specific diseases versus somebody who may not be sure exactly what they're seeing. And when it comes to actually analyzing the data or synthesizing the data, it's obviously much more difficult to try to piece together a series of tweets and Facebook posts and even newspaper articles than it is when you're systematically recording every single case that comes in, taking down the same information, and then being able to analyze that. So I wanted to just highlight some of the innovative surveillance pioneers, as well as just give you 2 examples of what kind of tools are available that really showcase what this is. So I'm happy to say that ProMED was started in 1994, making us one of the earliest innovative disease detection systems. But there are certainly many others, such as GFIN out of Canada, the Medical Information System, HealthMap, who we partner with quite a bit. And if you've been to our website, you'll see our collaboration there. And perhaps the one that people are most familiar with which is google.org. They did flu trends, so they were looking at people, how often people were looking up flu, and then Googling flu, and then taking that information and trying to kind of map it out. But as we move forward and as innovation speeds up even more, I'm sure there are more initiatives that will surface as well. And certainly there have been more with varying degrees of success over the past decade. So just the two examples that I talked about, the first one being DoctorMe. So this is an app that's available in Thailand, and what it does is it allows people to report on their symptoms and then get advice related to that. So if they have a fever, what they should do, if they have a cold, or if they're feeling they have certain symptoms, what it might be. It also gives them some tools, such as being able to go to the local hospital, so being able to see where that is and easily get there, as well as in cases of emergency, they can press a button and have an ambulance sent to where they are. So this has been a very successful app over in Thailand. And another one, again, related to flu, is Flu Near You, which is a US-based system, and essentially people can sign up and they receive a weekly survey that asks them if they have any sort of flu-like symptoms. So we'll ask you if you have a headache, if you've had a runny nose, if you've actually been to the doctor, if you've been diagnosed with the flu. And this data is collected on a weekly basis and then used to create these trend maps to try to show kind of where there's an average level of symptoms, of flu-like symptoms, and maybe where there's an increase. And so they have quite a large network now, quite a large number of people who have signed up. And so they currently have over 1.3 million cumulative weekly surveys, which is quite impressive data. And so it's open to anyone in the US, and you can join, and it's a really great way to get a personal experience on what innovative surveillance looks like. So we've talked about traditional disease surveillance systems and innovative disease surveillance, but really they're complementary systems. So innovation does make a difference. Studies have shown a more than 50% reduction in time to detect an outbreak with the use of innovative disease surveillance methods in conjunction with traditional disease surveillance methods. So I think the in conjunction part here is really key. They're complementary. They are not standalone systems. So as you can see here, we have, the main advantages of innovative or non-traditional disease surveillance is the speed, which we'll talk a little bit about more, but the scalability and the sensitivity. So we're picking up a lot of information. We're picking up a lot of things that might be missed by the traditional. However, the traditional has that specificity, and it also has that confidence. So I mentioned it's systematic. Those sources that they're using are tried and tested, and they've had relationships for quite a bit of time. And so there's that level of confidence that when you receive information from them, you know what you're getting. With the non-traditional, there's always that extra step of vetting that information and making sure that it's reputable. So really, neither system should exist on its own, and they really are complementary. So let's take a look at what happens when you combine surveillance systems and really why it's important that they're complementary. So this is an epidemic curve, let's say for a measles outbreak. It could be for most diseases. But basically what this shows is that as time goes by, the number of cases of a disease will increase. And so faster detection really allows us to respond to things earlier. And the reason that's important is for example, we could use Ebola. The faster that we start detecting cases, the faster that we know that something is going on, and we mobilize, the more lives that can be saved. But even for other diseases or diseases that aren't even fatal, there are side effects, whether it's economic side effects or even just side effects from the disease, people you know, having long-term side effects from being infected with something, even if it's not fatal. So really getting into if there is an outbreak, getting there, mobilizing, moving resources, and being able to address the outbreak is so key. So if we start with sort of the biggest curve, this is, again, our routine or our traditional sort of, our routine disease reporting. So this is waiting until clinicians and laboratories report on what they see. So waiting until the patient comes to the doctor, and then the doctor says, okay, this is a case of measles. I need to report this to my local health department. That information gets tabulated. And then, you know, whether it's on a weekly basis or a monthly basis, and then suddenly after some time, someone notices that, you know, there's an uptick, there's something going on here, and we need to respond. So that has the advantage of it being routine, but as you can see, that generates quite a lot of cases because of the time delay. So then we have these astute observers. So this was going back to our example of the 5 cases. This is really when somebody is clued in and perceptive and recognizes that, wait a minute, I just saw 5 measles cases in a row. There's something going on here. And so they sort of sound the alarm. So this, again, this moves us a little bit closer to the beginning of the outbreak and results in fewer cases occurring. But it's still a long way from the beginning of the outbreak. And then we have sentinel surveillance. So I mentioned this briefly, but essentially a center where, you know, for a disease, they're used to seeing a lot of cases, and so they've decided to operate as a reporting, essentially a reporting station, knowing that they're probably going to see a lot of cases of something if there is an uptick. So again, this is moving us closer to the beginning of an outbreak. It's reducing the number of overall cases that we're going to see. And it uses fewer resources because it's an established system, but we're still seeing quite a lot of cases there. So innovative surveillance, so what we just talked about. This is, again, using the non-traditional sources, you know, letting us detect things faster. So whether, sure, we might have some false positives, but it may be that we're able to really identify an outbreak with the first few cases that occur, and moving us that much closer to the start. And then finally, there's future innovations. So this is what's going to happen in the future. This is what we have to look forward to. So new approaches that will let us shorten the time between the outbreak starting and disease detection. And really, and I'll talk a little bit about this, but if we focus in not just on human health, but also and human disease, but zoonotic diseases, and we're really keeping up with our surveillance on wildlife and animal populations and using the One Health model, this could be reduced even further. So I'd like to shift gears. I hope that was a nice background, but I'd like to shift gears and talk a little bit about what we do at ProMED. So ProMED is the program on monitoring emerging diseases. This is what our website looks like if you haven't seen it before. And as I mentioned, we do partner with HealthMap, and you can see in the bottom left-hand corner there our health map of a map of essentially our ProMED posts provided by HealthMap. So what is ProMED? So we're an internet-based reporting system for rapid global dissemination of information on infectious disease outbreaks and acute exposures to toxins in humans, animals, and plants. So we do subscribe to the One Health model. And we recognize that it's important to understand what's going on everywhere, not just among humans. So ProMED's free for anyone to sign up for. It's open access, so we publish everything on our website that we report on, and anyone can take a look at that. And it's accessible via email, so you can sign up for an email subscription. You can just go to the website and search, or just read the the top new posts, and we also have an app. So why, I mentioned One Health. So why is One Health important? Because 75% of newly emerging diseases in humans are zoonotic, and 70% of newly emerging diseases in animals come from wildlife. So we can't really ignore the connection that we have to our environment. And the One Health concept, for those of you who aren't familiar with it, is essentially that. It's recognizing how important the link is between people, between animals, and between the environment. So we don't exist in a vacuum, and certainly not when it comes to emerging and infectious diseases. And so we have to be conscious of what's going on with our animals, with wildlife, with plants, and just with the planet in general. So who's ProMED? So ProMED is made up of moderators who are infectious disease specialists, and whether that's human, veterinary, both in domestic and wildlife, as well as plants. And they're trained to recognize outbreaks of public health significance and using this non-traditional and informal media sources. So they're continuously monitoring what's going on in the news, in their networks, outside social media as well. And then creating posts that really that report on these emerging and re-emerging diseases and outbreaks. So where are we? So we currently have 59 staff or volunteers in 37 countries. So you can see here each of the little stars represents somebody who's either one of our moderators or a volunteer or rapporteur, who are helping to strengthen the ProMED system. So we've expanded definitely in the 22 years that we've been around, or 23 now, but we still have some gaps that we're looking to fill. And so how are we organized? So if you look at our website, you can see at the very top that we have a few different regions and a few different languages that we cover. So ProMED reports in English, Spanish, French, Portuguese, Arabic, and Russian. And we cover a variety of regions. So our main list, our ProMED mail list, covers global, but we also cover Latin America, both Anglophone and Francophone Africa, the Mekong Basin, the Russia, South Asia, and the Middle East and North Africa. And so I like to include this. We like to create word clouds. So this is created by ProMED's Assistant Program Director, John Ramatowski. But this is what ProMED was talking about in 2016. So we took all of our posts from 2016 and created these word clouds, which you can also see on our Facebook or our Twitter for different periods. But essentially, if you look at this, you can see just the breadth of diseases and things that are going on all around the world. And you can see that there's quite a mix of human as well as animals. So we have rabies, we have lumpy skin disease, there's anthrax, MERS. So these word clouds are really a great way to see everything that's sort of going on. And just to clarify that they're grouped by regions, so not necessarily where you see dengue, that's not necessarily where the majority of posts for Asia, for example, were on dengue, but it just means that within the Asia region that we were reporting a lot on dengue, a lot on MERS. In the US, we were reporting a lot on rabies, West Nile virus, and Zika, etc. So we've had quite a few successes over the years. So we were the first to report on a variety of really important outbreaks. Yellow fever in Bolivia in 1999. We reported on the post 9/11 anthrax mail attacks in the United States. We were one of the first to report on Ebola before it was actually diagnosed as Ebola. And we reported, and also actually our experts did quite a bit of of extra work around the spread of Zika in the Americas before it really became the known situation that it is. But we've also recently, for example, have really highlighted the highly pathogenic avian influenza outbreak among poultry in Europe that was going on last year and continues on now. So we're really working to strengthen, as we mentioned, the One Health approach is quite important to us, and that's something that we're really working to strengthen, and we're starting to see those successes as well. And so I just wanted to include this. This is hot off the press from yesterday, but ProMED male was considered by the Netherlands Early Warning Committee, along with the ECDC Roundtable report, as one of the most useful international information sources. So that was a really nice recognition there of the work that we do. But it just goes to show that innovative surveillance is really just as important as the traditional surveillance in order to be able to detect things as early as possible and move the needle on that. So ProMED has grown, as I mentioned, and here you can just see that more information is being disseminated every year by us. So we've increased the number of posts per day. This is just for our main global English network, but we currently average a little over 9 posts a day. So of course, there are many more than 9 reports on outbreaks, and that's where those our dedicated team of moderators who are experts in kind of teasing out what is the most salient and what is the most relevant to our mission. And we've also increased our subscribers. So we're currently actually just about at 84,000 subscribers all over the world. We have subscribers in every country in the world. And you can see we've been steadily increasing that. This is just showing the last 7 years, but ever since we began in 1994. So the last piece I just want to cover is our program EPICORE, which is another innovative component to the ProMED system. And I just want to mention also our partners with EPICORE, the Skull Global Threats Fund, TEFINET, and HealthMap. So EPICORE is a system that allows us to verify. So I talked earlier about the importance with innovative disease surveillance to be able to verify that information. So that's one thing that you lose a little bit going the informal route versus the traditional route. And so EPICORE is looking to bridge that gap. So what happens is ProMED experts look for leads regarding possible outbreaks. So that's what they do just as part of their ProMED role, looking at outbreaks around the world. And then when they find something that they're interested in, they send a request for information to these EPICORE members. So these are volunteers. They're field epidemiologists or have some advanced level of training and have spent some time working on the field. And so the ProMED expert or the ProMED moderator sends out a request and says, I just read this story, or I heard from somebody that that there are 20 cases of this disease in this village, or or that there's a polio outbreak occurring here. Can you confirm that, or do you have any further information? And what these members do is these members rely on their networks or their expertise or the fact that they're in the area where this potential outbreak is occurring in order to verify that. So they might have a contact at the state lab or at the county level lab or the province lab and be able to call them and say, I heard there were these cases. Have you guys seen anything? And and then their contact can confirm, yes, we know that it's polio, or no, that was a false report, something like that. And our EPICORE volunteers can then feed that information back and really strengthen the post and the accuracy of the post that the ProMED moderator is giving. And then that information, so that feedback, again, is shared globally on ProMED. So one thing to really note here is that, and I just want to spend a minute talking about that, is that it's a secure online network and reporting system. And so because, you know, we're conscious of people, people's positions and wanting to create something that's a global community where people can come together to verify these disease outbreaks. So we've included this important anonymity features. So this, for example, is an example of what a request for information might look like. And somebody is responding. Obviously, this is not an actual response, but somebody is responding and giving further information about anthrax in India, a suspected case with humans and bovine. And so they have these options for sharing their responses on a what essentially ends up becoming a public forum when the ProMED post is composed. So someone might be happy, for example, to have this response attributed to them. They can also choose to, you know, to have the response quoted, but that any reference to them or anything, any kind of identifying details to them are removed. And they also might just say, you know, paraphrase, I really don't want anyone being able to identify me by this at all. And the reason I just wanted to stress this is because I think that we have a responsibility, you know, when we're asking people to report on information in an informal way, but helping us to verify, helping us to really, you know, move closer to that start of the outbreak, like in those epidemic curves, to, you know, to protect them. So when members join, and these are just the qualifications and the things that are the requirements to become an EPICORE volunteer, we do verify who they are and verify that, you know, that they meet these requirements. However, afterwards, we want people to feel that they are free to share the information that they want without worrying about any repercussions. So this is just really my last slide, and just to really summarize, so innovative digital disease surveillance can bring new levels of information, you know, faster reporting. We can get the information out there quicker. We don't have to wait, you know, a few days, a few weeks, a few months for an official report to come out. And it can provide easier access. So in the case of ProMED and a lot of surveillance systems, anyone can access it. Anyone can look at it at any time and get information. But like we talked about, they're complementary. So we still really need traditional surveillance. There's a lot of, you know, traditional surveillance has been around for a long time, and there's a reason that we still need it around. We need that, those systems in place. What the One Health is really, you know, the key approach to understanding what's going on, to being able to prevent disease outbreaks or anticipate disease outbreaks, prevent diseases from spreading, and also predicting future threats. So we really need to look at the world around us and understand how that's impacting the spread of infectious diseases. And through surveillance, we can really save lives, resources, and our environment. So, so it's certainly important. So that is the end of my talk. I'm happy to take any questions you might have, and for any of you interested in joining ProMED Mail or taking a look at EPICORE, or also just learning more about the International Society for Infectious Diseases, I've included our websites there. So thank you very much, and I'm happy to take any questions.
Maja, thanks for a wonderful presentation. We do have a couple of questions, but I just want to make sure that I reiterate. If anyone that is watching live on YouTube now, if you have questions, please just type them in the chat box, and then I will relay them over to Maja for a response. So our first question, first of all, you have a congratulations on your recognition with ECDC.
Thank you very much.
And then the first question is, does the verification process take too much time? And I'm not sure if it's in regards to the verification of becoming part of the EPICORE community, or if we're talking about verifying the actual surveillance. But
Yeah.
let's answer for the process of maybe surveillance first and then secondary EPICORE.
Sure. So I think when it comes to traditional surveillance, certainly that verification process, especially when it's being done through government channels, can be a limiting factor, and that's where the innovative surveillance really comes in. In terms of ProMED and EPICORE, so ProMED really prides itself on trying to turn everything around within 24 hours. So when one of our moderators comes across something, a story, or a report of an outbreak, we usually try to post that within 24 hours of that information being received. For the EPICORE verification, so what will usually happen, and I'm sorry, I should have included some examples, but what normally happens is that the moderator will post their initial post, their initial information about an outbreak, and then send this request for information to the EPICORE volunteers, and then follow-up information will be reported, so as a secondary post. So in that way, we can sort of sound the alarm, or get that first information out there as quickly as possible, and then provide any additional verification information or just more information in a follow-up post. And so usually we keep those RFIs. Our EPICORE members, volunteers, are really great, and they're usually quite responsive and respond within hours. But we do set sort of windows on how long we want to keep those open, in case we also know that obviously certain lab tests and certain verification processes just do take time, and there's nothing we can do about that. So we do try to keep that window open for a reasonable amount of time, depending on the disease or what's being reported, so that we can gather as much information as possible.
Great. So the next question is, in your experience, what could be the more practical way to systematically use both sources in routine reporting so that that trustworthiness grows?
So I think that responsibility, I guess, in some ways falls a lot on who is really mobilizing the resources. So I think, as we saw from the Netherlands group, I think they're probably relying on a variety of sources, and they've found that ProMED and the ECDC roundtable are really helpful for supplementing their traditional disease surveillance. So I don't think you can kind of have one without the other, but what we try to do, and what ProMED has been quite successful in based on the feedback we've received, is serving as maybe that early warning sign and prompting traditional disease surveillance, or prompting somebody to investigate through maybe a more traditional surveillance system to be able to verify that more quickly. So for example, if we alert, if somebody at CDC or somebody at WHO reads that, oh, there's certain suspected cases somewhere, they might deploy somebody out there, who's part of their traditional or part of their field surveillance group to investigate that specifically. And they might not have done that otherwise because they wouldn't have heard about it. And so I think that's the way that really, the more that traditional organizations kind of incorporate these innovative systems into their work, and try to use them to kind of guide the work that they're doing, I think that will really increase trust among both, and increase that the speed at which we can report on things.
Okay. The next question is there a page where significant institutions, maybe CDC or NIH, et cetera, put a list of what innovative systems they consider to be valid and or trustworthy?
That's a great question, and I don't actually know the answer to that. Not that I know of. So again, we know that that people in various governments and organizations use ProMED because they've contacted us sometimes, or you know, or just from knowing who our subscribers are, but not that I don't know of any page that specifically lists, you know, who any organization is using as surveillance sources.
Okay, that'd be something to look into for sure. We have one comment / questions which says, I don't have a background in health sciences or epidemiology, but am an experienced R Python programmer.
Mm-hmm.
Where can I volunteer to help with digital surveillance?
Oh, that's a great question. And again, I'm not sure. You know, I think that contacting organizations that you might be interested in. So certainly I'm happy for, I should have put my contact information up, but my email is just Maja, M-A-J-A, at promedmail.org. I'm happy for you to reach out to me, and I can potentially put you in touch with some other surveillance organizations, or, you know, happy to discuss further if you're interested in helping ProMED as well. But I think, you know, one of the things that as ProMED we do, since we are open access and free, is also that we're grant funded, and so I think a lot of other surveillance systems that are trying to, you know, be as transparent as possible have the same issues. So certainly any volunteers are always welcome. So.
Awesome. So I have a two-part question next. It says, with regards to the moderator-volunteer relationship, wouldn't volunteers be breaking protocol in some cases by sharing information from the government institutions that they work with? And then the second part is, what are your thoughts on the possible dilemma in professional ethics?
So certainly, you know, we leave that decision up to the volunteers. And that's why we have these levels of anonymity. I think that it's a difficult ethical question, you know, whether, and certainly not one that, you know, that we're capable of answering, which is why we do leave it up to the volunteers. But it's the question of whether, you know, the government has the right, for example, to withhold information or not when it comes to things like disease outbreaks, and whether, you know, that's harming others. And potentially, I mean, I think with Ebola, again, you know, if we had known things earlier and mobilized earlier, we certainly could have prevented a lot of death and suffering. And so is it ethical or not to withhold that information? And so we don't make judgments about that. We're completely apolitical at ProMED, and so we really leave it up to the volunteers in terms of deciding what they're comfortable sharing. And so that is why we leave that, that's why I emphasize that anonymity piece, so that if they can choose, you know, really what they want to share and what they feel comfortable sharing, and make that decision for themselves.
Awesome. Okay, we have another question. I guess this is about the EPI info that you obtain, and it says, is there a comparative statistical data which can be used for validation of the epidemic process, and where can it be obtained?
So we don't have, so again, we're a little bit on the smaller side of an organization. So we don't have, we have not been able to thus far really statistically analyze the data in our outbreaks. So we know from looking at, for example, when we first report on something to when WHO or other organizations issue reports on it, that we were the first. And in fact, a lot of times we're recognized in those reports as being the first to have mentioned it. But as far as I know, there's been some academic papers that I'm, again, happy to share if someone wants to get in touch, that have looked at sort of sensitivity and specificity of different surveillance systems, including ProMED. But we don't currently have a register of sort of how our disease reporting has been validated or not validated in a statistical way, sort of across the board.
Okay. Okay, so I just want to give people another opportunity. If you have any questions, please just type them in the chat box and I'll ask. In the meantime, Maya, I did have one question for you. So you talked in the beginning of your presentation about the various types of surveillance, and you said the last one is the future. And I'm just curious as to how ProMED may be engaging with young professionals and potentially students on really looking at the future of surveillance and what that may look like.
Yeah, so we're always open to hearing new ideas. I think we've been quite successful over our history in the way that things work, but we are constantly growing. So EPICORE, which was started really 3 years ago, but fully launched about a year ago, is sort of one of those ways that we're moving forward, but we always kind of welcome ideas. And one thing that we're trying to develop further, for example, is our app. So currently our app, you can submit information on the app, but we'd like to build that out and make that a lot more robust and include a lot of different features so that it can be really used in the field even. We've recently at our, so the International Society for Infectious Diseases, of which ProMED is a program, runs the International Meeting on Emerging Diseases every 2 years, usually in Vienna. So we just had this recently in 2016 in November. And as part of that, we included a hackathon, which was new for that year. We'll also be including one in our next conference, which is in Buenos Aires in March 2018. And so the hackathon really brought together a lot of young people who had no background, for example, in epidemiology, in surveillance, in medicine at all. And out of that came out a lot of really incredible ideas about how to map ProMED posts, also how to use ProMED data, for example, to look at rabies in Indonesia, just really innovative projects, and that we're hoping to really continue to support and move forward with. And you can see those on our website if you look at the our hackathon. So you can see it off of the isid.org website. And so we're really looking forward to welcoming even more students and young professionals from all backgrounds in Buenos Aires at our next meeting. And so more information about that is also on our website.
Okay. Thank you. So we have a couple of more questions that have come in. So I don't see the map in front of me, so I can't tell, but it asked about the inclusion of the Caribbean in ProMED. I guess it said specifically why the Caribbean is not included. So can you talk a little bit about the inclusion of the Caribbean?
So I think this is probably in terms of our staff and volunteers. So it's not a conscious decision at all to exclude the Caribbean, and we do report on things that are occurring in the Caribbean. Part of this is just how ProMED has grown, and as I mentioned, our funding and our support dictates a little bit of how ProMED has grown. So in the Caribbean, we're always interested. We definitely have EPICORE members who are in the Caribbean. And that's to say we do report on outbreaks and things going on in the Caribbean, and we'd be happy to look into growing our network there as well. So it's just partly a limitation on what we can do as a smaller organization.
Okay, and then next question is, how can we get in touch to obtain the info on specificity, and sensitivity of various surveillance systems?
Yeah, so the best thing to do would just be to shoot me an email. So I think I can just add it to the slide right now. But you can reach out to me. It's just Maja at ProMedMail.org. And I'm happy to share that information. So they're just from published papers that have looked at a few different surveillance systems.
Great, wonderful. So seeing no additional questions, I want to first, Maja, thank you for a wonderful presentation and just really bringing us forward into the innovative ways of digital surveillance and potential thoughts for the future and how the next generation can be engaged both with ProMed Mail, but also just disease surveillance at a local level. And I want to thank, obviously, all the participants who joined us online today. I ask that you subscribe to our page, our channel, so that you are aware of any upcoming webinars we have. And of course, if you do have any questions about ProMed, please get in touch with Maja. If you have any questions about the Next Generation Network, please be in touch with me. So thank you all and have a great rest of your day.
Thank you very much.